Good evening, everyone. Thank you for joining us. My name is Dr. Esther Kim, and I wanted to welcome you to Ask the Experts, a conversation hosted by SCAD Alliance. And I'll be moderating the conversation, but we have some esteemed panelists who I will ask to introduce themselves in just a minute. As you know, February is Heart Month, and today is our special Heart Month SCAD Q&A. Thanks very much to all of you who've submitted great questions in advance for our panelists to respond to. This way, we're able to cover as many topics as possible in the hour. We're recording the webinar and we'll host it on our YouTube channel so you can view it again or share it as well. So now I will go ahead and ask our panelists to introduce themselves. Do you want to go first, Daniella?
Sure, yeah. Thanks so much for having me. I'm excited to be here with everybody. My name is Daniella Kadian-Dadov. I'm a vascular medicine specialist at Mount Sinai in New York City, and I see a lot of fibromuscular dysplasia and other arteriopathies in addition to SCAD.
Agnes?
Hi, everybody. Happy to be here. My name's Agnes Koczo. I'm one of the cardiologists at the University of Pittsburgh Medical Center. I'm one of the SCAD clinic care providers in Pittsburgh, and happy to share some of my knowledge with you guys today.
Lori?
Hi, I'm Lori Tam. I'm a cardiologist at Providence Heart Institute in Portland, Oregon, and medical director of the Providence Women's Heart Program. I staff our SCAD clinic here and also part of the iSCAD registry. So thank you for having me.
Great. Hannah?
Hi, everybody, and thank you for having me here today. My name is Hannah Chaudry. I'm an interventional cardiologist at Dartmouth-Hitchcock Medical Center. And I often see SCAD patients when they come into the cath lab to have their angiograms and also follow them in the clinics as well.
Great. Thank you. Hannah, your audio is just a little muffled. I don't know if there's anything we can do to adjust that so we can hear clearer.
Sure. I can
Okay. And while Dr. Chaudry does that, again, my name is Dr. Esther Kim. I am in Charlotte, North Carolina at Atrium Health, Sanger Heart and Vascular Institute. I'm a vascular cardiologist and the national principal investigator of the iSCAD registry. And all of the physicians featured here are also site investigators for the iSCAD registry. I guess we will dive right in because even though the hour seems like it's a lot of time, it really isn't when we have so much to talk about. So many questions sent in around, oh gosh, where do I even start? All right. So Dr. Kadian-Dadov, many questions about activity restrictions. And it seems like maybe some of the top questions asked here are about activity and exercise guidelines. One of the questions specifically says, what are some of the number one things we should not do after having a SCAD attack? And I may group some of these together because they are similar in nature. I experienced a SCAD and a vertebral dissection at the same time following a full-term pregnancy and delivery. What are other common areas of the body to be aware of for additional artery dissections? What are the warning signs and symptoms of dissections in other arteries? And if I have SCAD and FMD, should I take more precautions so that I don't have another SCAD? That's a lot of questions all in one, but I'll let you take the floor.
I'll take a stab at it. Thank you. No, these are all really great questions and things that commonly come up after going through something like this. And so what I'll say is that we don't have any evidence that if you have SCAD related to FMD, that your outcomes are different than someone who has SCAD that is not FMD related, with the exception of perhaps having a genetic condition that we can identify that may have caused a dissection. And that's kind of a separate group. Regardless if you have FMD or not, if you've had SCAD, the recommendations that I give my patients after they have an event are the same. And basically, the idea is that we want to prevent excess stress on the artery walls. Number one, so that we can allow the artery to heal that's had a dissection, and two, prevent a recurrence from happening. And so just some kind of practical advice along those lines are exercise is actually a good thing. We want you to do cardio. You should be warming up and cooling down. Ideally, after SCAD, getting into a cardiac rehab program can be really helpful, both for your physical, but also mental and emotional recovery to exercise in a monitored environment. Beyond that, I would say that once you're out and doing it on your own, you should be able to finish a sentence without totally gasping for air during cardio. If you're pushing yourself to the level that you're really huffing and puffing and you can't finish a sentence, that might be too much. That might be going a little too far with your exercise. We don't generally give weight limits. I would say those of us that see a lot of these patients have moved away from that. But you should not be lifting to the point that you need to breath hold or bear down. If you're getting to that point, then what you're lifting is too heavy, and you can actually be increasing your blood pressure from inside the body. Beyond that, it's things like no chiropractic neck manipulation to protect the neck arteries, and making sure that you're controlling your blood pressure, making sure your numbers are below 130/80 most of the time. Those are kind of some general, I would say, guidance that I give people. I may have missed one of the questions, Esther. I'm
Yeah, I
sorry.
was going to repeat that for you because I threw like 5 of them at you at one time. Questions about what are some of the warning signs for dissections in other areas of the body, and why do some people have so many dissections all at once?
Yeah, it's a great question, and I don't think it's one that there is a clear answer to. A lot of the times it seems to be kind of a perfect storm. In some patients, we can identify triggers. It may be things like being postpartum or lifting a couch during moving, or having some sort of injury in that way that precipitates a dissection event. But for a lot of people, we can't point the finger at any one reason why the dissection has happened at that moment. Whatever's going on in the person's body tends to allow for dissections to happen around the incident event, meaning that usually your highest risk for a repeat dissection tends to be around the time that you've had the dissection. And as you move out from that, even by a month, your risk drops dramatically. So hard to answer that question, but there seems to be something going on in the person's body that allows for that to happen at that moment in time. And again, a really thorough evaluation with your doctor to find the triggers is super important if you can identify anything. In terms of symptoms, it's usually pain. And it's going to be pain at the location of the dissection. So if it's the abdominal arteries, you'll feel it in the abdomen or down in the pelvic area. SCAD, chest pain. And then for the neck arteries, neck or headache pain is common. So that's really what you're looking out for, something that's out of norm for you, or if you're someone who has pain in those locations, pain that's not going away with your typical measures, you should check in with your doctor.
Thank you. For Dr. Tam, there's a question here. I'm confused as to the recovery process. SCAD happens, you're placed on meds and heart rest to allow for healing. So why do so many of us continue to have chest pain and tightness if the artery has healed? And along those same lines, why are there so many ongoing symptoms, even if you are on meds or even if you aren't on meds after a SCAD?
So I will first say that it's quite common for women who've had SCAD to continue to have some intermittent chest pain at times. Initially, from their initial diagnosis, patients will have quite a bit more chest pain for a while, sometimes even for a month or two in the process of healing. As we realize with SCAD, we usually try not to stent. We know that in certain cases we will, but most of these cases will resolve on their own with some time with healing. I describe it kind of like if there's a hematoma or a tear within the layers of the artery walls, well, you've got like a giant collection of blood that's there. And it's going to take your body a while to reabsorb that whole hematoma and that blood. And in the process, you will heal, hopefully, that dissection, but it will take some time. So most patients leave the hospital, if we're conservatively managing them, meaning we don't put in stents or do big interventions, you still have a dissection when you leave the hospital. You're going to continue to have some pain for a while until that dissection heals up. So in the initial phase, you will continue to have some pain, and I tell my patients to expect that. If it's mild and minimal, it's getting better with rest, or sometimes there's a variable response to things like nitroglycerin, which we usually use for traditional atherosclerotic coronary disease. Sometimes it does help. Some patients will find that it's not that helpful. But if it's mild, minimal, not really significant, you can probably continue to just monitor it and it'll gradually get better. A lot of patients, there's a bit of an overlap syndrome. A lot of our SCAD patients also have some degree of microvascular dysfunction or endothelial dysfunction, meaning that your blood vessels are a bit more reactive and you can have spasm. And sometimes the chest discomfort that we get even later on is related to some of that microvascular dysfunction or spasm in the arteries. And in those cases, sometimes anti-anginal medicines, which dilate the blood vessels, like sublingual nitroglycerin or nitrates or calcium channel blockers, or even ranolazine I've used as another anti-anginal medicine, sometimes that can be helpful in patients who have chronic chest pain or intermittent recurrent chest pain from SCAD. That being said, there is a small number of patients that have recurrent SCAD. So if they're getting really severe, significant chest discomfort, I still want to make sure patients take that seriously. I will often have them come in for a troponin, cardiac enzyme check, ECGs, just or have them, be evaluated in our emergency room, just to make sure that they're not having an actual infarct or ischemia from their discomfort. But it can be a bit disconcerting because some of these patients will continue to have some intermittent chest pain at times.
Thank you. Here's one for our interventional cardiologist. In terms of the acute management of SCAD, what specific factors lead one person to need an open heart surgery, another person to need a stent, and yet another person can be treated with medicines, even though it's all SCAD?
Can you guys hear me a little bit better now?
A little bit.
Okay, I'm not sure what's going on with my microphone, but I'll try to talk clearly and loudly. That's a really good question. Obviously SCAD is the same entity, but patients get treated in a variety of different manners. In general, I would say that when we diagnose somebody with SCAD, the initial impulse is to leave it alone and let it heal, because SCAD will heal for most patients. I think the general idea around who gets stents and bypass really depends on how that artery is being affected by the dissection, how extensive the dissection is, and what it's actually doing to the artery. So some people's tears are minimal and the artery still continues to have flow. If that is the case, we oftentimes leave it alone. We treat it with medications and it heals itself. In that situation, the artery is still providing blood flow to the muscle tissue, and so hopefully whatever damage is occurring is minimal and you're still getting enough blood flow to the muscle. If the artery is completely occluded, so if that hematoma is large enough to completely occlude the blood vessel, depending on the size of the blood vessel, the location of the blood vessel, how important it is, sometimes we can't leave it closed. If it's an LAD, which is, kind of the classic widowmaker artery, it's a proximal vessel, it's the beginning of the artery, it's a large portion of your heart tissue that's being affected and it's completely closed. People don't generally tolerate that for long periods of time. And, if we think about how long it takes for SCAD to heal, it's generally, the first month or 30 days. That's a long time to leave an artery closed. So often in those situations, we are forced to put stents in, if that's appropriate. In cases where stents are either unable to be placed, if that dissection is extensive and we can't get our wire into the true lumen of the artery, or there are other reasons, the patient is very sick, and there are various kind of hemodynamic reasons why we sometimes will opt to send people for bypass surgery and also stent. So it's kind of case by case and how much of the heart is affected, which arteries are affected, and what is the extent of the compromise in the blood vessel.
Yeah, thank you. It's a complex issue, and a lot of times we have to do multidisciplinary planning where we have both the surgeon and the interventional cardiologist kind of trying to figure out if anything needs to be done, and if yes, what needs to be done. So thank you. Okay, Dr. Koczo, many questions about hormone replacement therapy, pregnancy, the effect of hormones on SCAD. So why don't we start with one? Is pregnancy after SCAD an option? Is there any new research about the possible recurrence of SCAD in post-SCAD pregnancies that may help to direct us?
Great, thanks, Dr. Kim. And I think it's not a coincidence we get a lot of questions about, around pregnancy and around menopause, and it's really because epidemiologically, we see SCAD is more commonly in women, and the time and across a woman's life when we see it most commonly is in the perimenopausal stage and in the sort of immediate postpartum stage. And so, a lot of times, if I see a patient, with postpartum SCAD, questions will come up about subsequent pregnancies and what the data is. So we have, some data. We would love more on looking at women that have had, pregnancy-associated SCAD and go on to have subsequent pregnancies. While that sort of small amount of data doesn't suggest the risk of recurrent SCAD in your next pregnancy is higher, what I tell patients is, and in general, SCAD that's associated with pregnancy tends to be more severe. So like Dr. Chaudry was saying, it can tend to occur in the sort of proximal part of the vessel instead of the distal. So it's impacting more of the heart muscle because the SCAD is happening at sort of an earlier part of the blood flow. Patients can come in and their heart muscle is very weakened. They can come in with really low blood pressure and what we call cardiogenic shock. So overall, the picture of patients coming in with postpartum SCAD tends to be more severe than women or men that have SCAD at other parts of their life. And so thinking about how severe that can be, I do tend to tell patients about that and sort of caution patients with, if it does happen again, it can tend to be very severe. And for those reasons, it's always a conversation between my patients and I. But, just thinking about whether there's other ways for family expansion, of which there are many wonderful ways, is worth a conversation with both myself and a maternal fetal medicine obstetrician colleague to really figure out what's best for the patient. And so that's sort of with pregnancy. I didn't. Do you want me to sort of go on and talk about menopause? I wasn't sure if we.
Why don't we save that one, because there are many questions about menopause.
Okay.
I'll just together. Okay, back to you, Dr. Kadian-Dadov. What is the link between SCAD and FMD? Maybe even start with what is FMD? And what additional testing should I have to rule out any underlying conditions after a SCAD?
Yeah, great. So FMD, fibromuscular dysplasia, is an artery condition that affects mostly women. It affects the architecture of the wall of the artery, and its characteristic appearance is a string of beads. So what you end up getting is an overgrowth in one of the three layers of the wall of the artery that causes it to narrow and then dilate, narrow and dilate to make that beaded pattern. And that's something we can identify with imaging. Preferably with a CAT scan, because for those of you that have had an MRI, you know that you have to stay inside that small tube and be really still and try not to move. And if we get any movement on the MRI, it can sometimes create what looks like beads that are not really there, or sometimes an image that's not good enough resolution to give a clear answer. Now, some people with FMD will also experience a dissection or aneurysm as part of their condition. And an aneurysm is when the artery is bigger than it should be, but not all FMD patients. So because of that link, the manifestation of heart artery involvement with FMD is SCAD. We don't really see string of beads in that location. People present with SCAD when they have heart arteries involved. But when patients experience a dissection, that is a reason to do further imaging with a CT angiogram, preferably from the head to the pelvis, to look for any evidence of FMD, the string of beads, or other aneurysms or dissections. Now, patients that have FMD, the string of beads, also should get that same evaluation, head to pelvis CTA, to look for associated aneurysms or dissections, because that's going to change their follow-up pattern, whether or not they need repeat imaging, et cetera. So that's the understanding in the link between these two entities. Did I miss a question?
No, I think that was perfect.
Oh, okay.
And the other thing that I like to tell patients, I'm not doing the CT scans to look for FMD because the SCAD has already happened, but we know that FMD, as you said, goes along with aneurysms and other dissections, and perhaps there are other vascular territories that we need to monitor over time. So thank you for that.
That reminds me, Esther, I'm so sorry, because I think it was one of the questions that was in there, whether or not further evaluation needs to happen if you've had other aneurysms or dissections, but no string of beads, FMD seen. Right. So there are some people in that situation where we don't see the string of beads, but we see other aneurysms or dissections in the body, or they have a family history of aneurysms or dissections, or someone who's died suddenly at a young age. And those are patients in whom I will usually do genetic testing and look for other reasons or other causes of aneurysm or dissection.
Okay, Dr. Tam, back to you. Can you give us a little bit more insight, because many recurrence questions. Let's do what they call level set. What is the recurrence rate contemporary data, and are there things that we can do to prevent recurrence?
So I think that this has varied quite a bit, because some of the earlier studies would quote higher rates of recurrence, somewhere closer to like 15%. And then the more current data would suggest that that number is lower, probably around the 5% range, something like that. So different registries and studies have shown varying numbers. But, I think that patients who've had SCAD invalidity, because of the spontaneous nature, are very concerned about their risk of recurrence. And I'll say, if you think about it as glass empty or half full, if the rate of recurrence is 5%, 10%, there's probably a 95% chance it won't happen again. And it took this many years for the first episode to occur. But I think that if your SCAD was triggered by a certain trigger, whether it be a physiologic trigger like a strenuous physical exertion, heavy lifting, Valsalva type weightlifting, or emotional stress, there's certainly some things that you can control. I've had a number of patients develop SCAD after doing something really strenuous. One lady was picking up a heavy planter in her yard and, was straining, and then very shortly thereafter started getting chest pain. I had a man, it's very rare for men to get SCAD, but a man said, I was working off a new trainer at the gym, and I was feeling good. The trainer was, really pushing me, and I thought I was doing really well. And then shortly thereafter, I started getting this severe pressure and had to lay down on the floor of the gym because I had felt like I had this huge brick on my chest and I couldn't breathe. So I think that if it was triggered by a physical activity, we want to try to avoid doing that. I've had people get SCAD doing kettlebells in CrossFit or Orange Theory. Well, we know not to do that. So I think the things that I usually tell my in consultation, tell my SCAD patients is that you want to avoid heavy Valsalva type weightlifting, where you're kind of bearing down, holding your breath and doing heavy lifting. You want to be able to breathe out and breathe throughout your lifting, and not do anything that is overly strenuous or heavy. Moderate aerobic exercise is acceptable, but really high level exercise where you're doing the extremes, especially, would be advised against, especially without proper warm up and cool down. And then, for most of our SCAD patients, we treat them with beta blockers long term if they can tolerate it, because by decreasing the heart rate, we feel like that decreasing the shear stress against the walls of the heart may make you less prone to recurrent SCAD events in the future. So both, I think, paying attention to the physical things you can do in terms of avoiding potential triggers, and then being on appropriate medical therapy in certain cases of beta blocker, if you can tolerate it, may help reduce your risk of potential recurrence in the future.
Fantastic. Thank you. Dr. Chaudry, so question about bypass surgeries. There was a question about a person who had bypass surgery, but one of their grafts is now gone. Is that something that we see? Does bypass or stent prevent another dissection from happening?
Yeah, so good question. I'm going to answer the second one first. So unfortunately, neither bypass nor stents will prevent you from having another SCAD episode, largely because SCAD is a completely separate entity from atherosclerotic disease. So in atherosclerosis, basically you have plaque buildup and cholesterol buildup, which then can basically become a scab, and it ruptures, it forms a clot on top of it. And that's how you have a classic heart attack. In SCAD, unfortunately, it is the makeup of your arteries that is abnormal and predisposed to creating either these dissections or filling with hematoma. And stenting, although stenting actually doesn't prevent you from having more plaque buildup either, will not prevent another SCAD from happening because we're not stenting all of the arteries, right? You still have your own arteries that are still at risk for having another dissection event. And similarly, bypass, I think bypass is a little bit different because rather than fixing the actual area where the SCAD happened, you are now rerouting the blood around where the SCAD happened. So say you were to have another SCAD episode in a proximal area to where the bypass is, it's possible you may not have the same type of symptoms or reaction to that because you already have a graft that's bypassing the blood. But getting to the first question, the important thing to remember is that bypass grafts actually stay open based on lack of flow in your native arteries. So because grafts are largely veins, so there's two different types of grafts. There's arterial grafts and vein grafts. Veins are not used to performing like arteries, so those grafts are very dependent on flow. If the flow in your native artery is greater than the flow in the vein graft, it's very likely that the graft will close itself down. So this becomes an issue when we're thinking about bypass for SCAD patients in particular, largely because we know that SCAD tends to heal itself. So say you have a SCAD episode in a large artery, you then get a bypass graft to it downstream, but over time, your own artery heals itself and you then restore blood flow into your native artery. There's a high likelihood or a certain percentage likelihood that that graft will close itself down. Now, that may or may not cause problems in the blood flow related to your own heart, but sometimes it can. Similarly, our arteries are built to perform like arteries. So if you put an arterial graft on a SCAD, the flow dynamics are altered. And so it can be sometimes challenging to decide whether or not you're going to put a bypass graft on and which type of graft you're going to put on a patient with SCAD, because the dynamics, the flow dynamics can be altered once the SCAD heals.
Yeah, so if I heard you, in contrast to cholesterol plaque blockages, which stay fixed and blocked, SCAD lesions tend to heal. And so then the bypass, which was rerouting the blood, is no longer needed and kind of closes back up. That was a great question. Back to Dr. Agnes. You mentioned that SCAD seems to occur around the time of pregnancy and around the time of menopause. And around the time of menopause, people start worrying about their bone health and weight and brain fog, and many want to go on hormone replacement therapy. So the question is hormone replacement therapy safe? And if it is, which ones? And if it's not, what are some alternatives?
Yeah. Great question. So yeah, I think perimenopause and menopause can come with, unfortunately, a lot of different types of symptoms. And because, the average age of women around perimenopause, 45 to 55, is also kind of around the age that most commonly women experience SCAD. It's a common question that comes up. Again, because of the times that women have SCAD, there is this hypothesis that it's estrogen, and really the fluctuation of estrogen or estrogen depletion, like what might happen postpartum and what happens in peri and postmenopause, that fluctuation of estrogen could be a trigger or some etiology of that SCAD event happening at that time of life. Because of that reason and because of that hypothesis, in general, we do, or at least I caution patients against introducing hormone replacement therapy, whether it's estrogen or estrogen and progesterone, around that time for their symptoms. Now, it's, perimenopausal and menopausal symptoms are a huge quality of life thing. And the good news is, for many different types of menopausal symptoms, there's alternative therapies. There's a lot of data on, what we would sort of classify as antidepressive or some pain types of medication that, even if you're not depressed or have chronic pain, are really effective for different types of menopausal symptoms. Really, hormone replacement therapy is first line for vasomotor symptoms or hot flashes, which can be very bothersome. And there's not only sort of alternatives to hormone therapy. So there's a drug called Veozah that just came out that I talk to a lot of patients about, but essentially non-hormonal therapies that are really effective for hot flashes. And then sometimes hot flashes will keep people up at night, and there's great data for actually gabapentin, or again, alternative to hormone therapies for menopausal symptoms. So in summary, in general, I caution patients about estrogen-based hormone replacement therapy because of this estrogen hypothesis causing the SCAD event. And I tell them, good news, there's a lot of alternative sort of types of therapies that can help for symptom control.
Great, thank you. Okay, Dr. Daniella. We know that patients with SCAD and patients with FMD as well have lots of headaches, can have lots of headaches and migraines, and some of them have been asked not to take over-the-counter pain medications such as NSAIDs. Why is that? And also, are there medications that you would recommend avoiding for the treatment of migraines?
Yes. So very true. There's a lot of overlap between migraine headaches and both of these conditions. I actually don't counsel against over-the-counter medications like NSAIDs for migraines if you need it once in a while. Now, if it's something that you're needing daily, that's a problem because it can start to actually cause problems like high blood pressure or kidney issues or GI upset. And so for those reasons, and rebound headaches. So for those reasons, they're not to be taken daily. But if it's something you need every once in a while, from my perspective, it's probably fine to take, even if you're requiring aspirin for the treatment of your FMD or SCAD. You can still take, the occasional NSAID, Motrin, ibuprofen, and that would be just fine. Medications to avoid would be the triptan medications. And those have been around for a long time. They work really well for breaking migraine headaches, but they also can cause the arteries to spasm. And that could be that additional stress on the artery that might precipitate a dissection. So it's just kind of risk avoidance that we're going for. The good news is there's a lot of really great migraine medications that have come to the market. The CGRP inhibitors, medications like Nurtec, Ubrelvy, to break your migraine. For those of you that have severe migraine headaches, they have injectable versions that are given once a month, and they can really cut down on your number of migraine days. So I would highly encourage you, if you're suffering, to talk to your doctor or neurologist or headache neurology if you have access to that, because there's a lot of really great options out there for the treatment of these that don't require those medications that'll put you at risk.
Thank you. Dr. Tam, back to you. I really liked this question here. It was, do I have to be on my medicines forever? What is the current standard for SCAD medicines? For instance, antiplatelet agents, beta blockers, even questions about, is it safe to take the new GLP-1 agonists for weight loss? So could
Lots
you
of
provide some clarity around medications that we absolutely recommend, and then medications that might be, in the popular press that patients are worried about taking?
hmm So, mostly for these SCAD patients, they're discharged on usually an aspirin and a beta blocker. And the aspirin, we initially would treat patients for a year or continuously because we kind of extrapolated that data from typical coronary artery disease from atherosclerosis. We now don't really have great data to say that an aspirin is all that beneficial long term. So I think most of us will treat patients with aspirin anywhere from 3 months to a year, somewhere in there, but unless they have fibromuscular dysplasia, we don't necessarily require them to stay on the aspirin long term. But I usually have a discussion with patients. I think, beyond the initial period, we don't really know for sure whether there's great benefit to the aspirin if you don't have FMD with the history of SCAD. And, if they're not having bleeding issues and they feel fine continuing, I'm fine with them continuing. But if you don't have any stents, if you don't have FMD, you don't have to stay on aspirin indefinitely. Now, with regards to the beta blocker, if patients can tolerate it, I do recommend staying on it just because theoretically being on a beta blocker with lowering the heart rate and decreasing shear stress against the walls of the arteries, you may have a reduced risk of recurrence in the future. We don't have, great randomized long-term kind of studies looking at that, but there is some thought that that is the case, and I will usually still keep them on a beta blocker if they tolerate it. Now, many of these our SCAD patients are young women who are small framed, tend to have soft, kind of low blood pressures to start with, so or lower normal blood pressure. So if they really can't tolerate it because they're getting low blood pressures in the 80s and they're dizzy and not feeling well, then those will be times when we will discontinue or allow them to be off of beta blockers. But there's usually no indication for statins in patients who've had SCAD unless they have atherosclerosis or they have high cholesterol that warrants treatment of their cholesterol, but with a medication separate from their SCAD. So we don't put patients on statins for SCAD alone. The other question is usually about Plavix or clopidogrel and treating with dual antiplatelet therapy. So in patients who do not require stenting or intervention, their current registry data would suggest that there is no benefit and maybe even some increase in harm. So we are not routinely treating patients with Plavix after a SCAD event if we're treating it medically. If they end up getting intervention, meaning a stent or something, we will still treat with that per the current guidelines for patients who are stented. In terms of GLP-1s, it's such a popular topic. So the question is it safe to take a GLP-1 if you've had a history of SCAD?
What
And I
are
don't,
some examples of GLP-1?
pardon?
What are some examples of GLP-1s?
Yeah, so GLP-1 medications are a class of medications which would include Ozempic, Wegovy, semaglutide. So these are all medications that in recent years has been approved for management of not just diabetes but also for weight loss. These medicines started as diabetes medicines, and we've used it, and it's usually and it works well for diabetes. But one of the side effects is you actually have weight loss. So a number of patients have had significant weight loss on these meds, and it's now been approved for weight loss as well, but very rarely covered by insurance for the most part for weight loss alone. But there have also been more recent studies. The SELECT trial demonstrated a decrease in cardiovascular events in patients with coronary artery disease, atherosclerosis, on patients with GLP-1s. And then there's also been a trial that the STEP-HF trial demonstrated improvement in outcomes in patients who have heart failure with preserved ejection fraction in terms of symptoms on GLP-1. So we're starting to use GLP-1s a lot more widely in cardiology. But we don't really know the impact of GLP-1s on SCAD. There's been no studies in that. So I don't have not seen any signals which would suggest harm, but none of us would say that there's any clear benefit that we know of yet with regards to SCAD and GLP-1. So I'm not stopping my patients from going on GLP-1s if they want to, if they've had a history of SCAD, just because I don't have data to say that it's not safe. I also don't have any long-term data to say that it's safe. So it's kind of at that point, a mutual decision made, with informed decision making with the patient, I think, at that point. I don't know if anybody else has other thoughts about that.
The only thing I'll say is that the GLP-1 agents are shown to have a lot of great other benefits, probably associated with weight loss. One of them is lowering blood pressure, and we know hypertension control is really important for SCAD recurrence. And so I do tell my patients sometimes it has the added benefit of controlling your blood pressure a little better. But like you say, Dr. Tam, I think there's no data, certainly in SCAD, and really no long-term data. So.
But that, your comment did trigger something in me that we're about to go into the next iteration of the registry, and we should probably be obtaining this data, whether patients are on GLP-1 agonists and also SGLT2 inhibitors, and see if that makes any difference. So thank you for that, Dr. Tam. Back to you, Dr. Chaudry. Okay, I feel like I'm asking you all the technical questions, but as an interventional cardiologist, you can handle this. Can you tell us what a troponin is? And what does it mean when your troponin level is high? And does it mean your heart is healed if your troponin goes back to normal? Does it mean your chest pain isn't from the heart if your troponin is normal? So basically, if I were to summarize my own questions, can you ask how should we be using the troponins in clinical practice, and what does it mean for patients?
Yeah, I think the troponins are always challenging, especially for cardiologists, because they very often get checked, and sometimes we don't really know what to do with them. So in general, when we think about a troponin and its elevation, it means that there is some insult or injury to the heart muscle tissue, and it has released an enzyme into the bloodstream that signals that. Now, classically, people tend to think that when troponins are elevated, there is either a blockage or some obstruction of blood flow to the heart muscle tissue, which has caused ischemia or infarction, and that has then released the troponin into the bloodstream. Now, we know that troponins, especially now the newer generation of very high sensitivity troponins, so sometimes you see people who have, sneezed and they bump a troponin that's in jest, but it almost feels that way. The high sensitivity troponins are very, very sensitive, and that just basically tells us that if your high sensitivity troponin is negative, there's a low likelihood of having a cardiovascular event, and that's really how they're helpful. They're not very helpful when we see them elevated, and there are degrees of elevations that are more helpful and less helpful. So oftentimes, if the high sensitivity troponin is elevated to a certain degree and it rises and falls, it gives us an indication that maybe we should be worried that there is some kind of blockage or heart problem or lack of blood flow occurring. Now, we also know that lack of blood flow can happen for other reasons that are not blockage or obstruction related, but more kind of supply demand mismatch. So when the heart is requiring more blood flow than it can get. So sometimes when people have really bad infections, sepsis, when they are sick for other reasons, bad pneumonia, your heart can demand more blood than it is being supplied. The classic example is anemia. So when you drop your blood counts very low, you can develop a troponin elevation because your heart is demanding more oxygen, and the demand is more than what it can keep up with. So I think troponins can be challenging, specifically when we're looking at patients with SCAD. I think Dr. Tam talked about all of the other reasons why women with SCAD can have chest pain, and some of those are not recurrent SCAD. Some of those are, entities like microvascular dysfunction, vasospasm. All of these things can potentially, cause you to have a troponin elevation. So it doesn't necessarily mean that you have had another SCAD episode just because your troponin is elevated. I think it's important to kind of think about more than just the troponin. What does the clinical picture look like? Is it very similar to your prior episode? Are you having the same type of symptoms? Does your echocardiogram show a new area of the heart muscle that's not moving properly in conjugation with the elevation in troponin, and kind of how does the troponin elevation occur? Is it a small level that stays stable and then comes down, or is it a very high level that continues to rise and then comes down? So I think the troponin is, a piece of the puzzle, but it's not always the answer to what's going on.
Excellent. Thank you so much for breaking that down. It seems like we use troponin sometimes as a yes, no, but there are so many nuances, and you really have to understand how to put the number in the lab into context. Okay, Dr. Agnes, I really appreciate the patient who sent in this question and for your bravery in asking the question in this way. This question makes me really kind of want to cry, honestly. I struggle with fatigue and sadness about my limitations the further out I get from my event. Is it all in my head? So, Dr. Koczo, how do you counsel your patients in regards to mental health after SCAD, and how do you know when you need help or if it's just part of like the natural process of healing?
Yeah, thanks, Dr. Kim. I will say, anecdotally, and I tell my patients this, that I see a lot of patients, not only after SCAD, but after a major life event like a heart attack, have a lot of emotions around that. And I try and normalize that, particularly with SCAD. A lot of times you're young, you're healthy, it's so unexpected, and truly it's traumatic. Right? We know from our registry about a third of patients meet criteria for PTSD. And so I tell patients that, it can be expected to have a lot of emotions after it. And I say, in general, I think it's great to have good support networks. I think, I normalize, sometimes it's important to seek out help, whether it's communicating with me or seeking other sort of avenues to help and feel better. And I think particularly if over time things like fatigue and sadness aren't getting better, I really nudge patients to have it be a center of focus. And I tell people sometimes even the trigger for SCAD can be emotional. And so now it's a matter of, you had a heart attack and it's time to get really serious about helping in emotional regulation and sort of dealing with things that may be underlying, and then emotions that are really disruptive following the heart attack.
Anybody else want to check on the mental health, because this is such an important area?
Yeah, I would echo what Agnes said. I think this can't be underestimated in terms of its effect for the patient and for their families. And so if you're even directly after the event, if you're at a point where it is interfering with your ability to sleep or do your normal day to day, then I think you're at the point that you need help. And that's okay. And it may not mean you need it forever. Sometimes people need it for a short period of time, and then they come out of it with the help that they need to overcome it, and they no longer need medication help or counseling. But if you're at a point where it's interfering with your day to day, then I think you need help. And we are not going to get you feeling your best if we don't address everything, physical, emotional, and mental.
Yeah, very good. I remember at a patient conference that I hosted once, at the end of the conference, all the patients and I gathered for a picture at the front of the room, and all the caregivers were on the other side of the room. Most of them were husbands or spouses taking the picture, and something went off in my brain. Oh my goodness, we're only taking care of half of the people, or even less than half of the people affected by SCAD. And so I really wanted to take time to address this, because you may need help for your PTSD, your anxiety, and your depression, which again may just be temporary. Please seek help, but really important for your family members to also get help, because while you were in the ICU, while you were getting your stent or in surgery, your family had to worry about you, and it's been traumatic for them as well. So I've had several of my patients actually go to family counseling and heal together and recover together. So I would encourage the patients and their caregivers on the call to get help for everybody and heal together. So Daniella, back to you. I think a lot of patients do yoga. I don't really do yoga, but lots of patients have many questions about yoga. So if you've had a SCAD or if you've got FMD or you've had a dissection somewhere else, what's the deal with yoga? And it kind of goes to the bigger question of exactly like how can you tell what activities are okay and what are the activities that should be avoided?
Yeah, so I would say that I think your best barometer for what's going to be okay is how you're feeling. So if you're ever doing something and it doesn't feel right, or you don't feel good, or you get an echo of the symptoms that you had at the time of your SCAD event, I think that's your body telling you to not push through it and back off. When it comes to activities like yoga, I'm very okay with downward dog, going upside down. What I would tell my patients to avoid is, again, those positions that require them to really hold their breath or bear down, like holding a plank for a prolonged period of time. If they're really straining to do that, they may need to modify it, go from the knees, for example. And I also would say stay away from headstands or shoulder stands. Because that's just, again, additional stress on the arteries in the neck area. And we're really trying to protect all of the blood vessels. And so those are kind of my general guidelines, I would say.
Thank you. I know it's these questions are tough because we're never going to have randomized controlled trial data. So we have to use our common sense. Dr. Tam, I frequently get surprised by what people do. They live such cool lives. They go to remote places. They travel to places where there might not be a hospital for hundreds of miles or a plane ride to a hospital. What do you tell your patients who want to travel after a SCAD, particularly if they're interested in going to remote places without immediate help?
It's always a difficult question, I think, for all patients of all types of cardiac disease. But I think that it's important that in the initial period that patients allow their SCAD to heal. So I usually would recommend cardiac rehab. I usually wait like a month or so before I start cardiac rehab just to allow for that initial dissection to heal. And then I tell them, why don't you go through cardiac rehab, do the 3 months. And if you are exercising, feeling well, doing well at cardiac rehab without any major symptoms or concerns, that's a pretty good test run that you can probably do some of those same activities on your own without being under medical surveillance or monitoring at that time. So I think that for patients that recover that initial period, they get through cardiac rehab and they're feeling well without major, concerning symptoms. I think at that point you need to live your life. This is a bit unpredictable, but the rate of recurrence overall is still low over the course of your lifetime. And I think if you're careful to avoid the triggers and the things that potentially could increase the risk, you have to live your life and do the things that you want to do within reasonable kind of risk. Some people choose to go skydiving. We know that's risky, but we choose to do the things that we want to do, and it's based on the kind of life we want to live. So the goal of treating you is to help you live your best life. And if your best life means that you want to travel and do those things, I think take your meds, be reasonable, avoid the triggers. But I think you should be able to live your life.
Yeah, I like that answer. We want to wrap our patients in bubble wrap, but probably not too healthy overall for the long span. Dr. Chaudry, this is a question I get asked in clinic all the time from patients and from doctors. If a patient who has a history of SCAD needs any sort of elective procedure or surgery, what is the advice that you provide to the doctors who are sending you that pre-op clearance form? And what are the things that you're telling your patients to discuss with their surgeon and their anesthesiologist?
Yeah, it's a good question. Obviously, we don't have a lot of data to inform us as to how we're supposed to be pre-oping patients specifically for SCAD, which is very different from, regular coronary artery disease where we, make sure that they have a certain level of activity and so forth. I think in particular for SCAD, it's important to make your physicians aware, and in particular, the anesthesiologist aware that you have had a SCAD episode. We all know that things like heart rate and blood pressure are important, and those things can be altered rapidly during induction and when people are coming out of anesthesia. So I think it's important for them to know that, that particular person is more prone to, or sensitive to wide ranges in blood pressure and in heart rate, and making sure that they monitor those very closely and are also cognizant of, things like chest pain afterwards and checking EKGs and things that, a normal 40-year-old wouldn't necessarily, the anesthesiologist wouldn't trigger to think about those types of things in the patient. So I think awareness is important, and just making sure everybody knows your history.
Thank you. And I think one of the keys is that we can each other. So that the surgeon and anesthesiologists are aware what SCAD is.
Right.
They might not be aware. So thank you for that. All right, Dr. Agnes, for my male patients out there, I'm going to ask this question on their behalf. Is it okay to take Viagra after SCAD?
So, when I think about Viagra, in general, in regards to my cardiac patients, the cautions I tell people to take is sometimes it can drop blood pressure, which in SCAD is not necessarily, a bad thing. I do caution patients, particularly with Viagra, that are taking other nitrates. If you do have, chest pain after your SCAD episode and you're taking, sublingual nitro or even a longer acting IMDUR, I caution them with use, particularly with the sublingual nitro, anywhere between 1 or 2 days, not taking it within 1 or 2 days of taking that sublingual nitro. So I think, overall safe with precautions. I think just for Viagra, correct? We were talking about.
Yep.
Okay.
Yeah. Thank you. So Daniella, lots of questions about FMD and arteriopathies and genetics. And I don't think we've hit the genetics part yet. Genetic testing is kind of confusing. Can you sort of go over for us, like, what is a variant of unknown significance? What does panel-based testing even mean? So if a patient gets genetic testing with a panel, does that mean that there isn't a genetic mutation, and that, we don't need to look again? Or, well, can you just give us a little primer on the genetics?
For sure. So it is confusing, I would say, for pretty much everybody who's involved. This is a rapidly evolving field. So currently, the panels that are out there that look for genetic mutations that cause aneurysm or dissection have about almost 30 genes that they can check for on them. And so if you get checked with that panel and your panel comes back negative, then you do not have any of those genes that are causing your aneurysms or dissections. It does not mean that you don't have a genetic mutation still, or that your condition is not genetic entirely, because there may still be genes out there that we don't know about yet. And so usually if you see a genetic counselor or talk with your provider after this, they'll say, check in with me in about 3 years, and we'll see if it makes sense to repeat testing if we have enough new genes that it makes sense to redo this evaluation. Now, when it comes to FMD, what gets even more confusing is that unlike the genes that are available on those panels, FMD is probably caused by multiple genetic mutations. So there are some conditions out there like Marfan's or Ehlers-Danlos, vascular Ehlers-Danlos, where it's one gene causing the condition, and they're pretty rare conditions. But with FMD, it's much more common, and it's probably multiple different genes that are working together to create the presentation for that patient. And it's probably explains why the presentation is so different patient to patient. Some patients with FMD get dissections and aneurysms, some don't, for example. And there is no genetic testing for FMD available today that's commercial. That is an active area of research. And maybe in the future we'll have something, but for now it's just not there. The last thing is this variant of unknown significance. So that result means that you did the panel and one of the genes has a mutation that's labeled a variant of unknown significance, meaning we don't know if it's disease causing or not. It may just be a mutation that's not doing anything. And so those specific results require a lot of attention and interpretation of the available literature to understand if further evaluation is needed or if we really think it's not doing anything and kind of how to handle it going forward.
Yeah, I often tell my patients, it's 2025 now, and so the genes we have now may be reclassified in the future as pathogenic, and there may be many more genes that are discovered 5 years from now. And so when there's a suspicion, we do think about going back to the geneticist several years after the first round of testing. Well, we are at 8:05. Hopefully we've gone through at least a lot of the groups of questions that are most commonly asked. I wanted to thank all of our panelists and also let our participants know that all of us, doctors and patients, want more data. And to update you on the iSCAD registry, which is the registry that we're all a part of, along with, I guess there's 6 of us, well, 1, 2, 3, 4, 5 of us. There's 25 other sites across the United States and Australia. We're going to be very excited to enroll our 2000th patient in a couple months. And yay! So in celebration of that, we would like to do another webinar to really share with the patients who've been so generous in sharing their data and personal information. What are we finding? What are the results of the registry? So we've had several papers published. We've had several abstracts presented at national meetings. But we haven't had a chance yet to break that down into a language that patients can understand in a webinar format. And so we will plan to do that in the next couple months. And so please join us for that. And I want to take the opportunity to thank the doctors on here again. It's incredible to me that we are all from different states. We've got people on the East Coast, the West Coast, and you are taking time from your families and your personal time to do this. So thank you so much. I want to thank SCAD Alliance for always being SCAD Alliance, for funding the registry, for providing support to patients. And as a reminder, the iSCAD registry is solely funded by SCAD Alliance. And if you are able and would like to contribute to the research that is being done and also contribute to the advocacy work that SCAD Alliance is doing and bringing patients together with doctors, please go onto the website and make a donation, because as you can see, your donation is going a long way to help educate and support patients as well as on for research. So thank you all. Have a great evening, and we've really enjoyed being with you. Good night.